Hey everyone, and welcome to this EMAS webinar. Thank you for joining us. My name is Antonio Cano, and I am past president of the European Menopause and Andropause Society. Before we begin, we would like to thank Abbott for the support and for making this new webinar series possible. The program and the contents are solely the responsibility of EMAS, the European Menopause and Andropause Society. Moving on to technical issues, you have entered this webinar into listen-only mode. That simply means that your microphone is muted, so we don't pick up any noise from your end. We do welcome and encourage you to submit your test questions via the Q&A widget located in your Zoom panel. You can enter your questions at any time, and we will read them during the session, actually at the end of the talk of the speaker. Additionally, this event will be simultaneously translated, and you can choose one of the following languages: Russian, Mandarin, Spanish, or Portuguese. You may select the language by clicking on the interpretation widget you will find in your Zoom panel. Finally, I remind you that we are recording today's webinar and it will be accessible on your website. Today, we have an excellent speaker who will address the issue of the use of menopausal hormone therapy. We have Dr. Andres Daste, who is a gynecologist and obstetrician with a specialization in endocrinology, gynecological endocrinology and menopause. He's a member of the Gynecological Endocrinology Clinic at Clínica del Country in Bogotá, Colombia. He's member of the Committee of Ethics and Research in the Center of Research, Clinical Research of the group Blue Card. So it's a pleasure to have him. And please, Andres, take the floor, and we are ready to listen to you.
Okay, thank you, Doctor, for this introduction, and thank to everybody to be here. For me, it's a real pleasure. My English is not very good looking, so I hope I will do my best to try you to understand what I'm trying to explain today. So I'm invited, and we're going to talk about when, for whom, which, and how long are we going to give some hormone therapy to our patients. As the professor says, I'm a gynecologist and I live in Colombia. Colombia, it's my country, excuse me, I'm trying to, okay. This is a part of my beautiful country. We are located in the north of South America. We have Iceland, like San Andres and Providencia. We have beautiful places like Caño Cristales. We have the Pacific Oceans where you can come to see the whales. We have mountains. We have a lot of towns. We have a lot of beautiful things. And also we have a lot of coffee. So I hope I can have you here in my country. We are nice people and we have a lot of things to share to everybody in the world. Thanks for inviting me. It's important to save some craziness for menopause. Also, I think it's very important to save some craziness, some madness for the andropause. Sometimes I think the men, we save a lot of crazes in our andropause, and it's fine that. I have no interest conflict in this conference. And I think it's very important to talk about the menopause syndrome. And it's very important because as we can see here in this picture, all in blue are the countries with more women than men. The proportion is not very high, but actually we have a lot of women in the world and they might need our help. So as we can see here, in the past years, the population is growing up, and the populations between 45 years and 80 years, as says in The Economist, is growing up because the life expectancy is getting high. So as we can see here in Europe, Oceania, Americas, we have a lot of ladies that is going to be more than 80, 85 years old. And all of them are going to have some symptoms in the menopause, and they will check for some relief for those symptoms. We calculate, and this is a very interesting topic, that, for example, in the 2050, there will be like 87 million persons in the United States older than 65 years. It will be like 22% of the whole population, and it's important to know what are going to offer to them. When I went to the medical school, the main issues for were the hypertension, were surgery, were some things on obstetricians, the deliveries, etc. And there is not too much attention to menopause. And now we know that to treat well the menopause will save lives. So it's important to have this in mind, and we can choose later on if we can discuss this thing. But I think it's very important that the general doctors knows a lot. They should know a lot of menopause management. In my country, is the same thing that the rest of the world. We have in the 2005 a population of about 42 million. Now we are 50 million. And the population of women between 40 years and 64 is, as you can see, growing up. So I think we have a lot of job to do here. Okay, Bogota is the capital of Colombia. It's located on the mountains, and it's a very beautiful city. It's modern and colonial, and has this juxtaposition in terms of architecture. So you can find like the picture here, and you can find all these modern things here. It's cold, so when you guys come here, please use a jacket. Today is sunny. Here it's 7 o'clock in the morning. And I hope I will see you soon here. Okay. What's the fundamental for hormone replacement therapy? Is this first picture. The follicle depletion is the cause of the menopause. And in the previously 10 years before the menopause, they accelerate these depletions. This will give us a reduction on both production of estrogen and progesterone. As a compensatory effect, the hypothesis will increase the production of FSH and LH to try to keep the production of estrogens, but sooner or later is going to diminish this critical quantity of estrogens, and we have all the menopause symptoms. So when we think what are going to do with this group of women, we have to think in two main objectives. First, to alleviate the troublesome menopausal symptoms, and the second one, to prevent the diseases of aging. I think two of them are the most important things that we have to think when we're seeing a woman with menopause. The FDA has approved these 4 indications for hormone therapy. It will be the vasomotor symptoms, prevention of bone loss, treatment of premature hypoestrogenemia, and treatment of genitourinary symptoms. These are the 4 approved indications by the FDA. The vasomotor symptoms, as we know, they reduce a lot of the quality of life. They start first time at night. After that, they will be maybe many times a day. They impair sleep quality. They, as secondary, they produce irritability, difficulty in getting concentration, difficulties with short and long-term memory. And in some women, they produce muscle and joint discomfort. As we already know, the frequency of these vasomotor symptoms is very high. This is the principal reason, but that the woman goes to the doctor in the menopause, because they are, I think they are so symptomatic, and it impairs a lot the quality of life. It presents in about 85% of the women at menopause. The average duration will be like 5 years, but in 25% of these women will last for about more than 5 years. In the WHI, last 7.4 years, and was linked to risk, cardiovascular, bone, and cognitive. It presents some ethnic differences, are more frequently in Black race, women with previously premenstrual syndrome, sedentary life, and low socioeconomic level. We can find a lot of difference between these symptomatic symptoms, these vasomotor symptoms in different countries. In Latin America, will be in about 50% of the people, the ladies, and Turkey is like more than 90%. When we take a patient to a surgery and we took out the ovaries, the symptoms will start very soon. So it's important that first important to try to conserve the ovaries, as we can see later. But if we have to take it out, we have to explain that the symptoms will start sooner. Smoking and obesity might also predispose a woman to more severe or frequent hot flushes. So, the genitourinary syndrome of menopause will compromise 3 important parts: labia, vagina, urethra, and bladder. And what we have is a lot of symptoms. The principal symptoms of the genitourinary syndrome of menopause will be genital dryness, diminished lubrication and pain, dyspareunia, burning and irritation, urgency, dysuria, recurrent urinary tract infections, and bleeding during sex. The signs that we can find when we see these patients are decreasing humidity and altered elasticity. When we have this alteration in elasticity and humidity, we find in this woman some incontinence. That is what is giving them the pain during sexual intercourse. We can find the labia minora resorption, and sometimes we don't find it. Vaginal erythema, fragility, urethral eversion of prolapse, introital stenosis, all those vaginal roughness. The introital stenosis can be so bad, so critical, that the woman can have sexual intercourse, and sometimes we have to use some things to help them, mechanical. I think when we are in this point, it's because she has a lot of time without treatment. So the genitourinary syndrome of menopause will give us 2 main sources of symptoms. First one will be the vulvovaginal symptoms and sexual dysfunction. It presents in about 45 to 63% of these postmenopausal women. And as we said before, is they have experienced vaginal dryness, dyspareunia, vaginal irritation, itching sensation, vaginal tenderness, vaginal bleeding, or spotting during intercourse. 40% of these women reported also sexual dysfunction. 24% they refer a lack of desire, and 19% difficulties with the orgasm. The another part that they will complain about is the lower urinary tract dysfunction. And it's very important to know that about 15 to 20% of women aged from 65 to 70 years and 20 to 50% of women more than 80 years will have bacteriuria. And we can we have to know how many of these women with bacteriuria will develop an infection, and we have to be aware of that. About 10 to 20% has severe urgency, and almost 50% has urinary incontinence, as I said before, because they lose this elasticity and a lot of collagen and a lot of things that will help them to have some continence. The bone is another of the indication. It's another indication of the FDA to treatment. And we have to remember that the osteoporosis is a systemic skeletal disease and is characterized by decrease in bone strength and the risk of fragility fracture. The bone strength is determined by the combination of bone density and microarchitectural integrity. Postmenopausal osteoporosis results from failure to reach or peak of bone density or accelerated bone loss after the menopause or age-related bone loss. Normally, when we have estrogen deprivations, we have accelerated bone loss. Any one of these will put the woman in a risk of fragility fracture. When we think in this group of ladies, we have to think in what is the osteoprotection. As we can see here, not all the fractures in this group of women occurs when they have osteoporosis. So I think the main objective of the treatment is not just to treat osteoporosis, is prevent the fracture and give osteoprotection. And we can give this osteoprotection with estrogens, with exercise, with correct intake of calcium, vitamin D, etc. The estradiol has a lot of benefits on both mineral density, as we can see here, if we compare the placebo versus the estradiol. And this effect is related with the doses of estradiol, as we can see here in the lumbar spine of femoral neck. When we use a 0.25 milligrams of estradiol, or we use 0.5 milligrams of estradiol, or we use 1 milligram of estradiol, as we give more doses of estradiol, the effects in reduction of the bone loss is higher. Remember this algorithm because it's very interesting to know that when we are talking about a woman that goes to menopause, but also we need to give some osteoprotection, or if she has a very high risk of fracture that we measure in the densitometry, one of the tools that we have to treat these patients are the hormone therapy. We'll see later in the conference which kind of therapy are we going to give, but it's important to know that right now in women less than 60 years or less than 10 years past menopause, with no contraindications and also with a very high risk to have fracture, if they cannot have this another treatments like bisphosphonates, denosumab, teriparatide, etc., we can use hormone therapy. And as we see here, if we take patients between 50 and 59 or patients between 60 and 69 on 70 on 79, we can see the benefits to treat them with estrogens plus progestin in this case versus placebo. We can see a very important reduction in total fractures. Encanto is a very nice movie it's a very new one from Disney, and it talks about Colombia. So when you see Encanto, try to remember us. It talks about our customs, and it's a very nice. I recommend it. It's very, very nice. Well, so the first part, we talk about why it's important to study menopause and which are the indications. The indication give us the conclusion of what are the people, the ladies or the women that we're going to treat with hormone therapy. But now we have to see which kind of therapy we have. And there is a lot of guides and there is a lot of consensus. And I think what we have is a very, very helpful tool to take a decision as a general gynecologist or as a general doctor or endocrinologist can use these tools to choose what will be better for each patient. And I think it's very important to know all of them. It's impossible to present all of them, but I'm going to talk about, for example, the global consensus statement of menopause hormone therapy. This is endorsed by the International Menopause Society, the NAMS, the Endocrine Society, and of course, the European Menopause and Andropause Society that has invited me here today. And it gives us some guidelines of what to think when we are facing a patient with menopause symptoms. It says that the menopause hormone therapy is the most effective treatment for vasomotor symptoms associated with menopause at any age, but the benefits are more likely to outweigh risk for symptomatic women before the age of 60 years or within the first 10 years after menopause. It's very important to have this in mind because it's not the same thing to treat a patient in as happened in the WHE of 70 years old with hormone replacement therapy than a patient of 55 years. This endothelium is different and the risk is higher in the first one. So it's very important to have this in mind when we're facing this group of patients. It says that it's effective and it's appropriated in the prevention, as we saw before, in the osteoporosis-related fractures in this group of patients. Some studies show a benefit of the use of hormone therapy, and they show that might decrease coronary heart disease in the group of patients that are taking estrogen alone. And also it's clear that it can reduce the mortality of another causes. The data on estrogen plus progesterone in this population show a similar trend to mortality, but in most randomized clinical trials, no significant increase or decrease in coronary heart disease has been found. The local dose of the estrogen therapy is preferred to use it in women whose symptoms are just limited to the genitourinary tract. In this group of patients, we prefer to use local estrogens. These estrogens, as a single systemic agent, is we can use it in patients with no uterus. When we have the uterus, we have to protect the endometrium with the use of additional of progesterone. The option of menopause hormone therapy, it's important to know that it's an individual decision, and this decision to start or not to start the therapy has to be on the analysis of the needs of the patients and the risk of this patient to have thromboembolism, stroke, ischemic heart attack, or breast cancer. The risk of venous thromboembolism and ischemic stroke with oral menopause hormone therapy, but the absolute risk is rare below age of 60 years. Some studies points to a lower risk when you use transdermal therapy. As we're going to see later, they are a very important issue when we talk to the patients about when or when not to give some hormone therapy, and is the risk of breast cancer. We'll talk later in this, but this increase is associated with the addition of progesterone, and it relates with the type of progesterone we use. Also, it's correlate. It's attributed to the duration of the use of the, and also to the kind of therapy we're using. The dose and the duration of the menopause hormone therapy should be consistent with the treatment goals and the safety issue, and should be individualized. In women with premature ovarian insufficiency, systemic menopause hormone therapy is recommended at least until the average age of natural menopause, as we're going to see later. It's not recommended the use custom of bioidentical hormone therapy. The data doesn't support the use of menopause hormone therapy in cancer survivors. This is the global consensus items that I think are very important, but also we can find some recommendation of another groups as the IMS. Basically, in some places says the same things, but I put the ones that I think are different, so we can think about this before take any decision. The hormone therapy includes a wide range of hormonal products, routes of administration, and all of them has different risks of benefits. It's important to know that before we offer this to any patient, and to read the studies about and to know what are the benefits and the risks of this particular therapy that we are going to offer. Women that has a menopause, iatrogenic, or are in ovarian failure, especially before 40 years, are in a higher risk of cardiovascular disease and osteoporosis. And also they have more risk of affective disorders and dementia. And the hormone therapy might reduce symptoms and preserve bone density, and it's advised at least until the average age of menopause. Counseling should convey the benefits and risk of hormone therapy in clear and comprehensible terms. When we talk with our patients, we have to explain very clear what we are going to offer and what will be the risk of them. The hormone therapy should not be recommended without a clear indication for the use. I don't know if it happens to a lot of doctors, but sometimes I have patients that they say, I'm not interested because I'm feeling good and I'm okay just doing some exercise and I'm taking vitamins and it's fine. If she doesn't have any indication to the use, it's not useful to start hormone therapy. they should go, these patients, every year to counseling. And this is the answer to the another question that we have at the start of the conference, is that until when are we going to give the hormone therapy? I have a professor that says, okay, until the next year, so the next consultation. It's important to encourage all this group of patients to go every year so we can make a physical examination to watch some of the laboratories to see how is the mammography, the echography, some labs, how is the tension, and etc., so we can take every year decision based in what we find and what she needs and where are we going to go with this patient. There is no indication to make, for example, mammography every 6 months when we have a patient in hormone therapy. It has to keep the same screening that we have in the group of patients without hormone therapy. They have to go to screening, for example, mammography or pap test, if she has some bleed, sonography, etc. But the reason that I'm saying this is because what I see is sometimes the patient that are taking some hormones, she's always afraid about the cancer and she wants to do the mammography every 6 months. So it's important to explain her, explain these ladies that it's not necessary to do it. Whether or not continuing therapy should be decided at the discretion of the well-informed woman or her professional, depend after the specific goals and objectives, estimation of ongoing individual benefits and risk. The dosage should be the one that gives relief for the symptoms. If it's a low amount, is better and should be titrated at every consult. So now we see to who, we see until when, we see how, and we're going to talk about what are we going to give them. So this is very important, and we'll resume what I tried to say before. Initiating menopause hormone therapy is individual decision in terms of quality of life and health priorities, as well as personal risk factors such as age, times since menopause, and the risk of thromboembolic trouble, stroke, ischemic heart, and breast cancer. The menopause hormone therapy should not be recommended without a clear indication of the use. The duration should be consistent with the treatment goals and the benefit-risk profile and must be individually reassessed every year. The type and the route administration should be consistent with the treatment goals, patient preference, and safety issues, and should be individualized. The dosage should be treated to the symptoms response and should be the most effective dose for that patient. Consideration of menopause hormone therapy for symptoms relief or osteoporosis prevention should be a part of our overall treatment strategy, including lifestyle recommendations. I think in this picture, this last part is the most important thing that we can talk to the patient when she goes to our office. And it's because the hormone therapy is helps, but is not a miracle. We should talk about diet, exercise, healthy life, and also we can give them hormone therapy. The hormone therapy is just a part of the whole strategy that we can give to these patients. Also, some of them will need some psychological help and some sexual counseling. And well, it's important to see them as a whole, as a as a woman who has a lot of needs, not just hormonal needs. So when we're talking about what we're going to give them, we have estrogen plus progesterone, tibolona, and basedoxifene. When we're talking about give estrogen replacement therapy, we have a lot of types. We have oral, and we can find micronized estradiol, estradiol valerato, or conjugated estrogens. We can give local estradiol and estriol. We can give transdermal estradiol in patch, gel, ring, or subcutaneous implants. The estrogens alone is given to a woman with no uterus, and we can try just to give the lowest dose to relieve the symptoms of each patient. When we have the uterus, we have to add progesterone. And this combination, we can find it in a lot of ways. We can find it orally. We can find it via transdermical, patches, gel, or we can find it a combination of the two of them. We can give them oral estrogens, transdermical estrogens with oral progesterone, or we can also put an intrauterine progesterone and also give some transdermical progesterone transdermical estrogens. It's important to know this, and the progesterone will act different as the origin of this progestin comes. For example, we will have anti-estrogenic effect, anti-androgenic effect, anti-mineralocorticoid effect, and glucocorticoid activities, etc. So when we face the patient and we know that we have to give some estrogens and we have to give them progesterone, we have to select what will be the best progesterone for this woman based on the effects of these progesterones. If we need more anti-androgenic effect, we'll choose a progesterone. If we don't need it, we use another one, etc., etc. We can give two kinds of therapy: continuously or cyclic. If we do cyclic, we give the whole month a continuous estrogen, and we'll give progesterone for 10 to 14 days each month. And it's recommended for this woman that is going close to the menopause. But when we have the woman that just passed the menopause, we can give them continuously therapy with everyday progesterone and everyday estrogens. Also, we have two options: tibolone and basedoxifene. Tibolone as an alternative to estrogen or as alternative to estrogen and progesterone. We don't need to use progesterone, we use tibolone. I think it's very good in treatment some genitourinary symptoms and also some sexual symptoms, and also alleviate the vasomotor symptoms. Has a very good effect on mood and atrophia urogenital, and doesn't cause vaginal bleeding, reduce bone loss, and the mastalgia is uncommon. The basedoxifene, as a selective estrogen receptor modulator, it's combined with estrogens, conjugate estrogens, to form a tissue selective estrogen complex. It has a good effect on bone, has a good effect on some urogenital atrophy, and also alleviates the vasomotor symptoms. What says the NICE? It says much more the same that we said before, but has two different things that I think are important, because sometimes we face patients that, or they don't want to have estrogens or hormone replacement therapy, or they can. So in these nice guidelines, they include the use of selective serotonin reuptake inhibitors or clonidine as alternative in these patients. They are not recommended as the first line treatment, but they can help. And also they talk about the isoflavones of black cohoes, and they're no more effective than placebo, but we are going to have a lot of patients that are taking isoflavones to relieve some hot flushes. About the sexual functions, if we can control this sexual function just with menopause hormone therapy, the addition of testosterone might be considered in this group of patients, because maybe improve some sexual desire and arousal problems. The psychological symptoms we can treat it with menopause hormone therapy, but it's important to know that the cognitive behavioral therapy alone or with hormones will alleviate low mood, which arise due to menopause. About the urogenital atrophy, we offer vaginal estrogen to women with urogenital atrophy. I think it's important to continue the treatment for as long as she needs them. We can talk with the patient every year to know how's the sexual life, how are the symptoms of genitourinary atrophy, and we can offer some different things, and we should keep giving the estrogen. The increase of the doses can be helpful if the symptoms are not relieved. And also we can help these ladies with moisturists and lubricants, additionally to the vaginal estrogens, especially the lubricants during the sexual intercourse and the moisturizers using every day. It's not necessary when we are just using topical estrogens to monitoring the endometrial thickness, as we have to do it sometimes with systemic hormone therapy. Okay. Another very important issue about the treatment is the premature ovarian insufficiency. It's important to talk with these young ladies because we have to explain the importance of starting hormonal treatment. We have to explain that the risk of diseases such as breast cancer and cardiovascular diseases are very low in women under 40, and they will have a lot of benefits using this hormone therapy until the age of the normal menopause, at about 48 or 50 years old. The hormone replacement therapy is not a contraceptive, so if they need a contraceptive, they should take some another contraceptive, or they should give them, or we should give them some anticonceptive by oral contraceptives. Remember that we try not to take the ovaries when we go to a surgery, because it will high the risk of death until the 80 years. And this is just to remember, we have to identify the main issues. If she has just urogenital symptoms, they should go to a vaginal therapy. If she has moderate to severe menopausal symptoms, we should consider hormone therapy. And if she has uterus intact, should use estrogen plus progesterone If she has no uterus, it's just estrogen, or we can use estrogen plus basedoxyfen or tivolone. And if she has only sexual dysfunction, we have to consider another psychological causes, and also the hormone therapy is recommended if it's not possible to relieve these symptoms. We can ask, or we can consider the use of tivolone or testosterone. And she doesn't have any symptoms, we can encourage to do some exercise, take care of herself, etc., etc., etc. This is just to remember that we have different kind of therapies that we just talked before about this, but it's like a resume of what we said before. It's another part of Encanto, and we have two main considerations we are talking about hormone replacement therapy, the breast cancer and the cardiovascular problems. I'm just going to say some things about the effects of hormone replacement therapy on breast cancer risk might depend on the type of therapy, the dose, the duration, the regimen, the route, and the prior exposure and individual characteristics. The WHI shows no increased risk on breast cancer in women who receive estrogen alone. And this is important when we talk with our patients. But in the group that has to receive estrogen plus progesterone, it's important to know that some of the progesterones can increase the breast density. And as we can see here, we find that some progesterones of medroxyprogesterone and levonorgestrel are associated with increasing the risk of breast cancer. Dihydrogesterone and natural progesterone doesn't increase the risk. And that it's because when see how they behave with the different cell lines, we see more apoptosis in natural progesterone, dihydrogesterone, or tivolone, and we see more proliferation of cells in medroxyprogesterone or DNOHs, for example. The thing is, when we talk with the patient, it's important to tell them this kind of issues, so we can take in the best decision for her. The best decision, the major items we discussed to them, best result for the therapy. And obviously the cardiovascular risk is important issue to talk about. As a resume, we know now that the hormone replacement therapy take all these risk factors, for example, in the syndrome, the metabolic syndrome, all of them will go down except some triglycerides and in transdermal therapy. But when we give a woman hormone therapy, we are protecting the cardiovascular system. So as we can see in the menopause, the tension, it tries to get higher. And when you use hormone therapy, we can see that the values of the systolic blood pressure and also the diastolic blood pressure goes down after 1 year of treatment. So thanks for this invitation. I hope I was clear, even if my English is not very good looking. Remember, here we have football, we have music, we have a lot of delicious things and food and beautiful places to come to Colombia. This is our group in the clinical country. We have a very nice group of people. We have Camilo Rueda, a lot of you guys know him, and all my partners. And about the conclusions, it's important to know that hormonal change during the menopausal period provide the rational use for the hormone therapy. The indication for menopause hormone therapy include moderate to severe climacteric symptoms, vaginal atrophy, osteoporosis, overactive bladder, and recurrent urinary tract infection. Estrogen replacement therapy is used as oral micronized estradiol, valerato estradiol, conjugated skin estrogens, transdermal estradiol patch, gel, ring, and local estradiol and estriol. Progesterones differ in the potency and clinical profile. Women frequently require a change on progesterone to achieve the endometrial protection without side effects. Various guidelines validate the application of hormone therapy in menopause. And thank you again, and I'll be here to answer some of the doubts that you can have. Thank you.
Okay, thank you, Andres, Dr. Daste. It has been an excellent talk. You have reviewed the main issues concerning hormone therapy, and it is interesting that you haven't missed the most debatable areas, like, for example, women with previous breast cancer or older women, for example. So I think there is plenty of stuff to debate, and for that, we have, you know that we have these questions and answers widget, in which we already have some questions. I'll start, I'm not sure you can access them. There is one question here from Dr. Mary McCaffrey. The question is if we can predict women likely to get an earlier menopause by knowing AMH, anti-Mullerian hormone, or antral follicular count in the late 30s, for example. Which is your opinion about that?
I think the answer is yes, maybe. If we have AMH lows, we know that the follicle depletion is very high in this patient, and so the answer is yes. We can think that she's going to be on menopause soon, but we don't use that to predict when is going to be this menopause issue. So we don't use it in the routinary study for the menopause patient. It's more useful in patients that go to infertility treatment to know which one of them will need a donation of ovule, for example.
Thank you. I think I totally agree with you. I think this is still a system which is immature to predict with precision the date of menopause. Also because the sensitivity is poor at the end of the reproductive stage. There is another question here. Sometimes we see women in their 70s who present with hot flashes and night sweats. They have not had these in their 50s. So this is something which is unusual, obviously, because you know that obviously most of the hot flashes start at the menopause, or even during the menopausal transition. But in this case, this woman didn't have them in her 50s, but she starts suffering these hot flashes at 70. When they went into the question is, the question also includes that other tests have been negative. So what shall we do with this lady, or with these ladies, this sort of ladies, ladies who start having symptoms late in the postmenopause? And I would add from myself also what to do with women who are under hormone therapy. And whenever you find that they are 60 or 65 or something, they want to continue with therapy because they feel very well and because they start having hot flashes if they interrupt the treatment. So you might probably address both situations. The lady who starts with the flashes when she's older, or the lady who is on the treatment but does not want to interrupt because flashes start again once she stops treatment.
Okay, the first thing that is the first time that a woman comes with this at the 70 with this issue, we have to study another causes of these symptoms. I mean, we have to study what's happening with the blood pressure and stuff like that. And she's not a candidate for the hormone replacement therapy. It's much more than 10 years after the start of menopause. And where if we start hormone therapy in these women, we will increase the risk of cardiovascular complications. So we can try, if it's just because of menopause, we can try cognitive behavioral therapy, we can try selective serotonin reuptake inhibitors, we can, if she can take, we can try clonidine, we can try a lot of different things that hormone to treat this group of women. And another group you said that was the woman that stops the hormone therapy and starts again with the symptoms, you said? Well, yeah, I think what we saw in the consensus and the IMS recommendation is to see them every year and to see what the goals and the needs for those patients are. If she keeps with the symptoms and if she needs the hormone therapy, and we have seen this woman for about 5, 6 to 7 years, and she needs the hormone therapy, she should take it.
Okay, thank you. Now we have another question here from Dr. Michel Moreau. The question is if there is a relation between menopausal hormone therapy dosage and the risk of breast cancer. So the point is dosage important in terms of risk for breast cancer?
Yeah, there is very issues when we're talking about the risk of breast cancer. One is the kind of progesterone that we're using in. Another, the time, how long are we using this hormone therapy, and obviously the dose, it's important. So what we have to do is try to relieve the symptoms with the lowest dose that we can use, and try to release the symptoms with a progesterone that doesn't increase the risk of breast cancer. Yeah. Excuse me, Doug, I can't hear.
Sorry, yes, I was saying that we are having plenty of questions. We have here another one from Dr. Jan Stepan. And the question is, the early menopausal transition is associated with a sharp rise in serum FSH levels, even when serum estrogen levels remain within normal limits. So what is the role of increased FSH in risk of symptoms such as osteoporosis, osteoarthritis, and changes in body composition? So the question is if there is any role for FSH in the development of osteoporosis, osteoarthritis, and even in changes in body composition.
Well, the FSH increases as a response to depletion of the production of estrogens by the ovary. So the main problem is not the elevation of the FSH. The real problem is the lack of estrogens, and that this lack of estrogens is the thing that will be associated with the osteoporosis and another complications. So to measure the FSH as a predictor factor for osteoporosis is not indicated. And what is important to know is that if we have symptoms and we have FSH, for example, in 50 and the estrogens are very low, we should talk to this patient to see if she is a candidate for hormone replacement therapy.
Thank you. I think it's a very good answer to a difficult question, actually. If I may add something, I am aware that there are some studies with rodents in which it seems that FSH indeed seems to have a role in those, in all of them, osteoporosis and particularly changes in body composition. But as far as I know, there is no indication or no proof that this has been the case in the human. But obviously, it's a very good question with which is very debatable. Here we have there is a clinical question. Here is Dr. Baylor. Also want to check how we manage patients when they are bleeding irregularly on sequential therapies, or if they start bleeding on continuous combined HRT regimes. Apart from ultrasound pelvis, is referral required each time? What urgency level of referral given the delays in the National Health Service? Thank you.
Okay, this is a very good question because it happens a lot. You know, the irregular bleeding sometimes is like a nightmare when you're starting hormone therapy. You can give more progesterone. First, you have to see if you don't have any trouble with the endometrium. Maybe you will have to take this patient to a biopsy, and you have to know that there is not any cancer or precancerous thing inside the endometrium. After you do that, maybe you can give more progesterone or more dose of estrogen to this patient, or you can try to put dew inside the uterus, the progesterone dew, and you can give the estrogen by transdermical or oral patches. You can try that. It's a very important issue, and the treatment should be individualized. It's this word is very hard for me in English. Individualized. Yeah, it is that.
Yes.
Okay, individualized. Thank you. Yeah, I think the first thing, the most important thing is to discard endometrial problems.
Okay, thank you. Again, another question similar to one that was already raised before is, what do you think about women older than 70 for hormone therapy? I think it has been already replied.
I think it's important because we cannot forget sometimes it's very difficult to express this answer in another language, but I'm going to try it. We cannot forget that the hormone therapy is just a part of the treatment of the menopause woman. It's just a part. And we cannot forget that we have cognitive behavioral therapy. We cannot forget that we have the selective serotonin reuptake. We cannot forget that we have the exercise. We cannot forget we have the good nutrition. For example, these groups of ladies, they can have osteoporosis. We have to check how is the bone density, how is the muscle, to avoid the sarcopenia. And I think it's very important for us to know that the only way to treatment a patient on menopause is not the hormone therapy. We have to treatment as a whole, as a person with tension, muscles, bones, etc., etc., etc. So the only way to treatment is not just the hormone therapy. We have to encourage to have a good nutrition, to do some exercise, etc.
Yeah, thank you. It's a very good answer. There is then here a question from Dr. McCaffrey again. Is there a limit to how long women can stay on Tibolon?
As we said before, until the next year.
Okay, excellent answer. Yeah. Okay. Another question here, which is the maximal thickness in the endometrium to consider of risk in a patient who is under hormone therapy, and when that thickness is a reason for interrupting the therapy? So
well, it's about 4 millimeters. When we have beyond 4 millimeters, we have to start thinking what is happening. If the patient is receiving hormone therapy, it depends if it's cyclic or if continuously, and it depends if it has bleed or doesn't have bleed. But anyway, at any suspicious that she has some issue inside the uterus, we should take a biopsy, and the decision will be accord or will be related with that biopsy.
Okay, many thanks. Well, I have plenty of questions. My God, here. Well, I think this has been already answered in the talk. Which progesterone is most associated with breast cancer? This is a question from Dr. Feros.
Yeah, we saw medroxyprogesterone. We saw in the diapositive, like before we presented, medroxyprogesterone, and we have less risk with natural progesterone, micronized or I think actually depends also for how long we give the patient the hormone, and depends on the risk factors. And I mean, what I'm trying to say is that it's not prescribed the use of medroxyprogesterone. What we see is that in the studies, the medroxyprogesterone, for example, has more consequences of density of the breast. So maybe you should take care if the person has some risk, not to use them, no?
Okay, many thanks. There is now a couple of questions which raise a similar issue. One is from Dr. Chavarri, and the other one is from Dr. Canales. And the question is if we have to consider the impact of a first level relative with breast cancer. So in one case is a sister of a woman who is 48, and the sister had a breast cancer, and now this lady starts with urogenital syndrome, reduction of libido, and the question in one of them is if we may use hormone therapy, and the other is if there is any help in using bioidentical hormones instead of menopausal hormone therapy.
Oh, it's a great question. It's a very complex question. So she has a sister that has cancer. The first thing is that the decision to take or not hormones doesn't depend just by the doctor, depends also of the patient. We have to explain her about the individual risks that she has. Just because her sister has cancer doesn't mean that she has cancer too. So after that, talk to the patient, she has to be able to take the decision to take or not to take the hormone therapy. And if the principal symptoms of this woman is problems with genitourinary syndromes, the local hormone therapy, it will not raise the risk of cancer, and we can use it. And if she has some trouble with sex issues like arousal, we can think in Tibolone as a treatment for them. I cannot recommend the use of label medicines to treat those patients. So by now, what says the consensus is just talking, define with the patients which kind of therapy are going to use them.
Okay, thank you. We have plenty of questions, I should say. Well, I will take only some of them because we may extend the duration of the webinar for a little while, but not so long. So there is here a question from Dr. Hansen. The question is, a woman, 12 years postmenopausal with symptoms who she requires menopausal hormone therapy. So the question is, does she still need progesterone, which gives her unpleasant side effects and withdrawal bleeding? So the question is, in a case of a woman who is already 12 years old, probably she's 62, 64, and she is symptomatic. And the question is, should we add progesterone or just take the risk because she's older and probably just by using only estrogen?
I think it's important to study the endometrium in her. And after that, if she needs progesterone, you can use it. But the first thing is study endometrium. What we have to discharge is that she doesn't have anything inside the endometrium, as polyp or hyperplasia or something like that.
Thank you. Then we have here a couple of questions which address a similar issue, which is if we may personalize the indication of menopausal hormone therapy. So go beyond the rules, let's say, just evaluate which is the status of the lady and then decide. And the questions are, one is if a lady has a high Q risk score greater than 20%, can menopausal hormone therapy be given after doing a risk assessment? So assess the risk. And then the other question, this was a question from Dr. Navani. And then there is another question here from Dr. Fangelicum. Shouldn't we try to make a more personalized estimation of the vascular age of a woman before we start or deny her menopausal hormone therapy, regardless of her time since menopause, for example, by doing a coronary calcium score, for example? So imagine that we may perform a computed tomography calcium score, and the result is excellent, but she's, let's say, 15 years since menopause. So can we still take this parameter to prescribe hormone therapy without any restriction? And the other one was the Q index in case it was high. So
I don't know what you think, Professor, but the recommendation has to be accord with the guidelines that we are having now. So I know we can do some coronary study to see what reflects of vascular status of each patient, but I cannot recommend the use of hormone therapy beyond the 10 years of start of menopause or after the time where the study says that it's better not to start. But well, you can check for a lot of studies. They have a plenty literature that is talking about the sonography of the carotid vessels. But right now, I cannot recommend the use after 10 years of onset of menopause.
Yeah, I agree with you.
I understand what he's putting on the table. I understand that he says maybe in that patients I can use that, remember that it's individualized, and remember that you should take that issue to the patient, and it should discuss with the patient what with the risk of the use of hormone therapy. But I cannot recommend it beyond 10 years.
Yeah, I agree with you. The CAC, the calcium score, is something which probably will help a lot in future. And I am aware that there is some research plans addressing this issue in future. But for the moment, if we stick to the rules, we shouldn't take it to decide the use of hormone therapy. But obviously, there is a very interesting rationality behind the proposal. Excellent question. Well, yeah. Shall we take one or two more, Andres? I should say that you have also many congratulations. I haven't said anything, but there is a list of people congratulating you for the excellent talk. So
even with my very bad look in English.
no, it's all right. It was excellent. It was excellent. So, well, there is a curious question here. I should say that some weeks ago, I gave a talk about pregnancy in older women, and I received the same question. This is the case of a patient who is perimenopausal, and she's lactating because she got pregnant whenever she was already 46 or 48, when she was old, something that is becoming more and more common nowadays. Usually because of the use of assisted reproduction. But the question is, if there is a lady lactating and she does not want to interrupt lactation, which would be the best option for treatment if she is symptomatic, because she's already with hot flashes and so on. The question is, can we give Tibolone, for example? She does not want hormonal contraceptives.
Well, the problem is that with Tibolone, we don't have studies in breast, in lactancia, in breastfeeding. We don't have studies with the Tibolone, so I will not recommend the use. Depends also in how long has been she with the after the delivery. If the delivery is soon delivery, like 3 months, she cannot use any kind of estrogens because will higher the risk of thrombosis of vessel thrombosis. So, and after that time, the Tibolone is not an option. Maybe she can use just progesterone contraceptive. It maybe help some with the relief some of the symptoms. Tibolone, definitely, I don't think it's indicated in that case.
Okay, many thanks. And now the last one. I have to stop now, but as I say, there is still a list of questions here. Something which is probably important to stress because this is something that should be clear. The question is, are migraines with aura a contraindication to hormonal therapy?
Yeah, as with the contraceptives.
Okay.
But we can source another things with these patients. Again, I repeat, we have a lot of things to do with this patient, not just estrogens. We can give her progestagens. We can use, maybe we can try Tibolona as a therapy. We have the cognitive behavioral therapy. I mean, there's a lot of things we can explore them, but definitely estrogens is not an option in that patients.
Okay, Andres. So I think we will leave you to go to your duties in the hospital. It's the early morning in Colombia now. So many thanks again for being there, for an excellent talk. It has been a pleasure to share with you this session. And many thanks to all of you, the attendees, for being there and for raising so many questions. in such an important topic as it is the use of menopausal hormone therapy. So I think that because of the interest, probably we will ask EMAS if there is another version of this talk, because it is raising much interest. Also, many thanks to EMAS for being there, and also to Abbott, obviously, for sponsoring this session, which, as I say, has been so useful and interesting. So have a very good day to all of you. Very good afternoon or evening for those who are in the corresponding parts in the planet, and have also a very good time in future. Thanks.
A big hug to everybody. Thank you. Bye-bye. Have a nice day.